Hi, I'm Daniel Nyman. On behalf of the Forum for Healthcare Strategists, as well as our colleagues at DexCare, welcome and thank you for joining us for Gaining Physician Trust in Digital Transformation. Gaining physician buy-in can make or break any digital initiative, yet many clinicians remain skeptical after past technologies created friction instead of improving care. So what are the keys to gaining trust? Our speakers today will explore just that. Joining us are Dr. Vanessa Diaz, a practicing primary care physician from MUSC Health, and Dr. Sonja Tarrago, a technology-focused clinical strategist at DexCare. They will share what truly resonates with clinicians when introducing digital solutions, along with lessons learned from real-world initiatives, including the rollout of a patient navigation technology at MUSC Health. A couple of notes before we begin. First, if you'd like to ask a question, please enter it into the question and answer pane on the bottom of your screen at any time. Our speakers will respond to as many questions as they can in the time we have. Second, we will be conducting some polls during the webinar, so please watch for them as your participation is appreciated. With that, I'll turn the program over to Sonja to get us started.
Great. Thanks so much, Daniel. And thank you to the Forum for Healthcare Strategists for hosting us today. Welcome to our session on gaining physician trust in digital transformation. My name is Dr. Sonja Tarrago. I'm a community pediatrician, now turned healthcare technology leader. I lead clinical strategy at DexCare, where my focus is on bringing the physician voice to technology and also helping my physician colleagues understand how technology can help them. I'm excited to partner on this webinar with Dr. Vanessa Diaz. I had the opportunity to meet Vanessa last fall in the beautiful city of Charleston, and I was really struck by her really grounded and intentional approach to digital transformation. So I'm excited about our discussion today. Vanessa, I'll hand it to you to introduce yourself and tell us a little bit about MUSC. And Vanessa, you're still on mute.
Here we go.
Perfect.
Hi, I'm Vanessa Diaz. I'm a family physician and I am the chief of MUSC's Primary Care Integrated Center of Clinical Excellence, which is basically a what we call our service lines. MUSC is a statewide institution. You'll see there we have 16 hospital with six more in development throughout the state. We're serving all 46 counties of South Carolina. And we'll focus on the ambulatory side here because this is where I do most of my work. And we have served more than 200,000 patients, more than in value-based contracts. So that means that they are in our primary care practices and almost 3 million patient encounters annually. I'll also say that we have about 70 primary care practices throughout the state. So it's a lot of primary care physicians that we work with. And one of the things that's lovely about MUSC is that we are very interested in innovation, but doing it in a way that is thoughtful, like you were saying, Sonia. So I'm very excited to be talking to folks here today.
Great. Thanks so much. I'll take a minute to tell you a little bit about DexCare. So DexCare is a patient navigation company built for healthcare. By healthcare, we were born out of digital innovation at Providence. And we help health systems to manage the how and the where patients receive the care that they need. What I'm most excited about the work that I do with DexCare is we improve healthcare access, which means we reduce time to visit for patients. We improve patient experience. We help them from searching for care to scheduling care. And we do that in a way that's sustainable for our physician colleagues and, in fact, could save time. So I'm going to kick us off with our agenda for our time today. I'm going to start with just setting the stage on some of our current challenges in healthcare, as well as historically how technology has impacted physicians. Then we'll move on to strategies to balance physician concerns about technology with health system organizational priorities. After that, we'll share approaches that we have seen drive meaningful provider adoption of technology. And we're going to finish all that with actionable tips for all of you to take back to your organizations for gaining clinician buy-in in technology. So let me start with just some context. So first of all, we all know that it takes too long for patients to get the care that they need. Across the US, on average, it takes a new patient over 3 weeks, 26 days, to get an appointment with a primary care provider. And for specialty appointments, the wait can be much longer than that. If we layer on top of that we still are seeing high levels of clinician burnout. Now, we've seen some improvement in the last couple years, but those levels are still quite high. In this 2024 AMA, American Medical Association survey, they found that 43% of physicians report at least one symptom of burnout. And we know that there's multiple contributing factors to clinician burnout: loss of control, inefficient care delivery models, and cognitive burden or cognitive overload. In fact, we know that administrative burden is the leading driver of clinician burnout. One example of that administrative burden is technology that causes friction. We see that our primary care colleagues are strained in particular by this. And I'll offer a specific example of administrative burden that stems from the EHR, from the electronic health record. So physicians spend nearly twice as much time on EHR work as on patient care. Another way to say that is for every 1 hour of patient care that we're providing, we're spending 2 hours in the EHR. I see Vanessa nodding. That's likely her personal experience. Now, we've seen some improvement in documentation times with recent introduction of ambient scribing, but I know my physician colleagues are still spending a lot of time documenting in the evenings, what we've traditionally called pajama time. So before I move us into specific discussions about strategies to improve physician adoption of technology, we'd like to kick things off with our first poll. So Daniel, can you open the first poll for us, please? Thank you. So we'll give our friends here just a minute. We invite your response to this question. When new digital tools are introduced, what matters most to clinicians? First, whether it preserves their clinical judgment and choice control. Secondly, whether it fits existing workflows without adding additional work. Or third, whether it improves patient outcomes in care. So Vanessa, as we give our friends here a minute to enter their response, I'm curious about when during your career did you start to hear conversations that highlight the need to pay particular attention to clinician concerns about technology? I will say for me, those conversations started probably 15 years ago when my first clinic went from paper to electronic health record. But tell me, when did you start hearing the need to really focus on these concerns?
100% agreed that I think many folks who went from that paper to EHR, electronic health record transition, felt that they didn't really have a voice in how the EHR ended up looking, and that it was not really consistent with their workflows, and they had to change workflows to adjust to the EHR. And so I distinctly remember that. And so I worked in paper long enough to remember, yeah, your hand really hurts and it's hard to write that many prescriptions sometimes, right? So so there's a tension there between sometimes even if something is probably going to be helpful, if we don't feel we have any voice in how it's implemented, it can feel very we can get a lot of pushback, right? And so I love the answers here, as we can see, right? I talked a little bit about how the workflow is, I think, one of the things that it's really important for us to make sure we're understand it, before we bring in digital solutions.
Yeah, I appreciate that. It's interesting. I think what seems to matter most to our audience is whether or not it fits into existing workflows. So you're spot on with that. I think I reflect back on when we went from paper charts, where if there was a note or a concern from a patient, I often just had to add my thoughts and then send it back to my nurse. And then all of a sudden, when we were electronic, we had thousands of messages in our inbox. So whether it fits into that existing workflows. We're also seeing some folks talk about whether it improves patient outcome and preserves judgment as well. So I'm going to move us on to just highlighting those three areas that clinicians are concerned about. So first is the area of control. So the questions we hear from our physician colleagues are, what choices will I have with this technology solution? Can I trust it? Is it credible? Is it validated? So that first area of concern is control. After that is workflow impact. So that's exactly what we just saw with our poll. How is it impacting people, not only my physician colleagues, but my staff? How is it impacting our time? Is it usable? Is it designed that I can find what I need, or do I have to click 5 extra places to get the information I need? What about change management? Will we need extra committees or governance for this technology solution? And then maybe what I think is most important here is interoperability. Does it integrate with our existing systems, or do we have to log in someplace else to get what we need? And then the third area of concern is outcomes. What is the effect on patient care, our relationships with our patients? Is it safe, or does it increase risk for adverse events? And then does it preserve data privacy? Vanessa, what would you add here about these clinician concerns?
So I think they're definitely spot on. And what I would kind of highlight is that, especially when we're looking at digital solutions, really thinking through what are the outcomes is really important, because if we don't measure it, we may implement it and we don't know what's changed. We don't know if it was worth the implementation work. And so it's really important to really think of that up front and not try to figure that out in the middle. Because any solution we want to have thought through, like you're saying, the workflow up front. What's the problem we're trying to fix? And it's interesting to me that when we did the poll, control was less than 10% of our providers. Um, because in and maybe it is that number, but I feel like a lot of times the loudest voices are
Yeah.
the ones that are concerned about that. And rightfully so, right? And I think part of what we want to talk about is, how do you give forum to to these conversations while still being able to move forward?
I appreciate that. So let's be clear on the problem we're trying to solve. Let's make sure that our outcomes reflect how we're doing with that problem. And then let's make sure that we set ourselves up for success for listening and gaining that input. I appreciate that. So these are the three areas of concern that we often hear clinicians weigh when digital initiatives are introduced. And when we look specifically at provider feedback about online self-scheduling for patients, I think the themes are similar. So we at DexCare last year in 2025 surveyed providers about their concerns about offering online scheduling. And I think the responses here reinforce that their hesitation of providers is really about their effect on their day-to-day. Who are the patients that are actually going to land on my schedule? So the first area of concern is clinical relevance. Maybe these visits are not suitable for self-scheduling. And in fact, that is true, but I would surmise that there are actually more visits that are suitable than at first glance. After that, the concerns really focused on, my schedule's too complicated. So do patients have the knowledge that they need to do this? And then third, not surprisingly, is capacity. My schedule is already full. So we're already seeing providers weigh the need for control over their schedule with expectations from their patients, with the effort needed from their staff to manage all this, and also whether self-scheduling actually makes sense for them. Any thoughts to add here, Vanessa?
Yes, I think as you mentioned, one of the things that we have found is that if you don't have a clear scheduling algorithm, and this is true of any workflow, right? Here we're happy to be talking about scheduling, but really of anything you're trying to fix, if you're not clear on what the workflow is, and there's a lot of, one-offs, this is done differently here, differently there, and we can't get to consensus, it does make it very hard to implement any solution. And so again, that's where identifying what are the visits that really are not suitable versus where are we maybe putting in the barriers administratively to say that's not how we've done it, so that's not how we want to do it is really important.
So again, understanding the workflows, right?
Yep.
Yeah, I love that. All right, so as we think about digital transformation projects, I think our goals are always to focus on the priorities of our health systems, our providers, and our clinicians. And particularly when we're looking at projects that are whose goal is to improve patient experience, like what we're going to be talking about today, if we need to balance the priorities of the health systems with the needs of the providers. And when we do that, both of those groups benefit, because what we've seen is that trust really grows when these digital projects for clinicians reduce burden, or at least don't add to burden. And for health systems, they show measurable ROI and value. So with that, I'm going to turn it over to Vanessa to talk with us more about digital transformation at MUSC.
Perfect. And I'm very happy to talk a little bit about our journey, and it's always a journey. And where you have to start is knowing where you want to end up, right? Otherwise, you can end up anywhere and think you've made great time to get there, right? And so, really, when we look at our digital transformation goals, enhancing our consumer care and experience was very important to us, right? We know that people are much more likely now to want to be able to not make a phone call, not wait on the phone to get their health care. They want to send those in-basket messages, which we can all have opinions about that quantity, but also, if they're making appointments and things like that, finding their care, they want it to be as easy as possible. We also want to support our care teams, right? So part of the other part that I think a lot of times the providers don't think about is that we have legions of people answering phones, trying to get people's answers and get them schedules in the right places and things like that. And so helping offset some of the pressure they're under allows them to really then be better able to focus on those very complicated patients that really do need more of that personal touch and not be spending their time on what is relatively more straightforward scheduling that the patient could be doing themselves. So how do we actually, the things we integrate, have it help our care teams be better able to do their jobs? We want to have innovation and impact, right? So I said up front, that's one of the things that we know healthcare is changing. We know that in 5 years, it's going to look completely different than it looks now. There's lots of technology and innovation coming, but how do you not innovate just for the sake of innovating and really make it something that's going to have impact? So that's definitely one of the goals. And then streamlining operations. We all, I'm sure, in whatever health systems or whatever care area we're in, have limited resources. One is certainly financial, but the other part, is a national trend, it's hard to even find enough people to hire, even if you had unlimited financial resources. And so, being able to streamline operations to be as efficient as possible is really important also.
And Vanessa, what does this look like in day to day in your meetings? Do you see your fellow leaders referring back to this list and saying, we've got this new proposal, does it fit within this bucket of goals? What's that look like for you?
Yeah, absolutely. I think one of the things that we we do model and walk the walk, if you will, is the first question is how does this impact the patient? Is it going to make it better, worse, harder, etc.? And then the second question is then how does it impact our care team members? And I'll tell you, a lot of times, if you can get those two things correct, the other two will come along
Wonderful.
kind of naturally. Kind of as I mentioned before, you do still need to think about them and make sure that you're not taking things for granted and that you're measuring the impact and things like that. But we always start with those first two things. Is it good for the patients? Is it good for our care team members?
Perfect. And then when you say we, tell us more about who we is.
Yes, that's the other thing where MUSC is very fortunate to have both clinical champions like myself for primary care, for specialty care, for our regions. You know, I said MUSC is very broad. And so we have clinical champions who can work closely with our digital transformation team. And having that team is really vital to be able to have the conversations that you need to have to be successful in digital transformation. I do not pretend that I would be the best at vetting how hard or easy is this digital tool to interface with our electronic health record. What are the expected metrics, feasible, reasonable, et cetera, right? So having a digital transformation team that can help guide us on those things where we get to then focus on here is what I want the solution to do. And they can often then go out and find the things, the digital tools that they think best will meet our needs. That's a really great partnership. We're all working to our strengths, but we're working together in a way that can make us successful.
I'm curious for clinician champions like yourself, how did you find yourself in this role? Did you express interest? Did someone invite you? What did that look like?
Yeah, that's a great question. So, it's funny because I would not be a person that I would call overly technology savvy. You know, my kids or my husband often are still the ones that are like troubleshooting our computers and things like that. But often said, I'm the perfect voice for the consumers because not everybody is that tech savvy, right? And so it's great to have a little bit of a spectrum of, I work with some other primary care providers who have every app and, every trick in the EHRs to, smart phrases and things like that to be as efficient as possible. And then obviously we have folks who still are using the EHR kind of more minimally or our digital tools more minimally. So kind of being in the middle and being able to think of both sides is very helpful. Obviously, I've learned a lot through this role, and again, that's where having that digital transformation team has been really helpful to be able to better understand what are the possibilities, what are the things that are coming. We'll often have meetings where they bring us what's new, right? They're going out to the digital meetings, and then they'll come back and say, these are the things that seem to be the hottest, or these are the things that we saw. And then we get to have a conversation of like, this is helpful, this isn't ready, etc. We do also at MUSC have what we call our IT medical directors, and I'm one of them. And again, it doesn't mean that you have to be the most savvy, but it's having that interest in how do we better integrate technology into the care we provide. And with those IT medical directors, we cover a gamut of our specialties, which again, it's important to make sure that you can not assume that everybody sees patients the same way, but instead understand some of the nuance.
So those are the folks who are understanding the problems, helping to pair those with solutions. I would also say that I suspect a lot of your role is relationship building. And so I suspect that you were invited based on the credibility you have with your colleagues as well. Thought we'd talk a little bit more about your process for digital transformation projects, if you'd sort of take us through the steps that you typically follow.
Absolutely. And I think that's where being a practicing clinician is helpful to me because I can speak to the difficulties. I can speak to some of the things I've done to help them be better and have a better, let's say, working vocabulary with our providers as we talk about problems. Because the first thing, whenever we're looking at digital transformation, is to align on the problem. And I'll tell you right now, there is innovation out there, lots of different tools. One of the things we've really tried to do is with our clinical champions and our digital transformation team, really align on what the priorities are and then have realistic timelines. So maybe something that's our biggest priority, it's going to take years to get to the point where it really fixes the problem the way we want to. Maybe that's not the best thing to jump into. Maybe there are things that are maybe slightly lower priorities, but much lower lying fruit, and able to be successful quickly. So aligning on the problem is really important. And to be able to do that, you do have to engage your physicians early. And you're exactly right, Sonia. One of the things we do is we have at least five different provider meetings in primary care based on region, and then academic departments. And that allows us to come to them with what we're working on, get their feedback. We will usually not try to implement something system wide right away because I was saying 70 practices, like 200 physicians or providers, that's too much, right? So our approach is general to start with three or four pilot practices or pilot physicians, and that's how we're engaging them early to get that feedback up front. And so then when we go to our larger provider practices, we can say, hey, we've already tried this. These are the results we got. This is the feedback. This is how we're changing it to make it better. So that goes right into the third step here, which is co-designing that workflow. We never expect it to be perfect right away. We are always very thankful of the folks who are willing to pilot with us because we know usually there's some iteration and improvement. So co-designing that workflow as we pilot things down. Aligning on value, that goes into discussing what are the right outcomes. So if it's about scheduling, is it that we're getting patients scheduled faster? Is it that we also look at, how many incorrect patients, and I put incorrect in quotes, right? But patients that had to be moved or such. And so really aligning on what is the impact that you want to see is really important. And that flows seamlessly as you're going through this process. So then execute a phased approach. That's where I was talking about. You really want to pilot. Depending on how big your system is, you can decide how quickly you want to roll things out. I will say sometimes we have definitely been a little too slow as we rolled out some of our digital tools. People are seeing the people in the pilot getting the impact of the benefit, and then they start asking, "Hey, when can I start? When are you getting to me?" So it's important to also be a little bit flexible as you're looking at the phased approach. There's been a couple of times where we say, well, everybody's really into this. Let's just open those gates because it people want to try this out. Whereas other times we have actually slowed down and said, you know what, this isn't getting to the point where we feel it's going to be helpful. So we need to go a little slower and make sure we work out some kinks before we move forward. So that's that phase approach. And then finally at the end, obviously it's collecting that feedback and adjusting again as needed. So it's that iterative process. And so one of the things I'll mention specifically is part, I think, of the trust that we gain from our providers is if they know, hey, we are trying this out. We're not pretending it's going to be perfect right away, but we want your feedback and we will work on this to try to make it as good as we can. And after we do that, if it's still not good enough, we don't have to continue it, but let's give it a chance. And I think if we are um, we set the expectations correctly and don't act like everything is going to be a panacea because it often is not. It takes work, right, to implement. I think that's really helpful to our providers, and they're much more willing to trial things with us that way.
Yeah, I think I will really emphasize those last 2 points about executing a phased approach with some flexibility. I think you'll share more about how that looked like in this particular project. Once some of your colleagues started to hear the wins in the project, they were eager to like, how do we get signed up for this? So I know that you'll share more about that. So I want to move us into specifically talking about your digital front door project. We've talked about sort of your goals for digital transformation at MUSC. Can you take us through the goals for this particular project?
Yeah, so we definitely had a somewhat old-fashioned approach to our digital front door. Uh, Most things were pushed through our patient portal, but not all our patients were signed up in our patient portal, and certainly new patients were not signed up for the patient portal. And so it wasn't really a very effective strategy, especially for new patients. But then just overall, some patients just didn't sign up for that. So we wanted to get them faster access to care, basically avoiding having to go through phone calls, phone trees, et cetera, anytime they wanted to make an appointment, be more intuitive, simplify patient navigation. So I can get on the website, I can easily see where I have to answer the questions and get to what I want, whatever kind of care I want. And then the other thing too is we knew we specifically wanted to target our specialties as a place where we wanted to make it easier to self-schedule. And again, just make it easier for patients to find the appointment that is easy or that is correct for them. I've had to make appointments where I sit there on the phone with the person going through my schedule. No, I'm sorry, Monday doesn't work. Do you have anything Tuesday afternoon? Oh, no, you don't. No, Friday doesn't work for me. What about next week? And it just spends time, and making that easier is definitely something we wanted to do because we also know that our patients do have choice. And if we make it too hard for them to get to us, they might choose somewhere else where it is easier for them. And one of the things that, as a primary care person, I'm definitely very aware of is we want to be convenient,
Mhm.
because we don't want to lose that opportunity to be able to take care of the patient.
So making it easy, efficient, accessible to your patients. So I appreciate those goals, but in order to achieve those goals, I know that you needed the support of providers and specialties. So can you tell us about your approach for gaining that support?
Absolutely. One of the things that was helpful to us in that is that we could see our metrics. And so the metrics we focused on is how long does it take you to as a patient from when you want that appointment to when you get that appointment scheduled. And it reflected kind of what you were showing up front there, Sonia, of like there was a big lag time. But then the other thing we looked at is what was our scheduling density in the sense of like, were all our appointments getting filled up? And is that why patients weren't able to get in? And in some areas, yes, it was an issue of we have too much demand, not enough patient slots, right? Or appointment slots available. But in some areas, we were seeing that schedules weren't getting filled and we were still, 30 days out for appointments. And being able to identify those areas gave us a place to start because that seems like that was a mismatch of I'm not getting the patient into the slots easily.
So would you say that that was data that you were pulling and then going out to these groups, meeting with these groups and sharing this data?
Absolutely, because I think we all know that human nature is to say, well, there's probably a problem, but it's not in my area. It's not our problem. And so being able to have that data, and obviously the way we use this data is to inform. We talk about trends, we talk about, they're directional. We never try to use it as a way to be punitive, but showing that data then did make our leaders consider what was going on and then be more open to solutions for the issues that we're seeing in the data.
And tell me, where were you sharing the data? Were you meeting virtually with providers and specialties? Were you going out to their clinics? What did that look like?
Yeah, that's a great question. So initially, we started with a division chief or department chair or ICE chief. So that level with the leadership, because we knew we needed them to be also part of the team that was getting the buy-in. Because as a primary care doctor, the surgeon may not be as willing to listen to me. But when they have their department chair coming and saying, "Hey, no, y'all, this really is a problem. It's affecting our bottom line. Let's figure out how to fix this." It helps, right? So that was one of the things is first sharing the data. And then honestly, sure, there were some times where it's like, well, you didn't pull this department, you didn't, you didn't include the APPs, things like that. So it also helped us make sure the data was correct enough because you certainly aren't going to gain any trust if you go and show data that people will then think it's incorrect. And then it will take you a long time to get them to believe your data if that happens, right? And so we did both of those things, show the data, understand the data, and then make sure we validated the data. And then we went with those chiefs and had, usually it was digital just because we have so many clinics all over the place, digital meetings with the providers and our ambulatory leadership. Sometimes they were in person when that worked out, and that was certainly good.
And what I suspect in those meetings is you heard pushback, you heard concerns. So tell us about some of the concerns that you heard during those meetings and how you responded to them.
Absolutely. So, one of the most common concerns was this is just gonna open it up. I'm gonna have all the wrong patients on my schedule, and the patients I really need to be seeing aren't going to be able to get on my schedule. And so talking through the process, giving them that autonomy to say, hey, you know what? There's algorithms here that, we can ask patients questions. We can, do what we need to do to try to help them end up in the right spot. So having that conversation was very helpful, and really a lot of times it was going through the first time listening to the concerns and then saying, okay, we're going to see what we can do, and then coming back with plans that then address those concerns. And then I think it's also the idea of sometimes when we are pushing back, we can assume that what we're doing right now is perfect. And so just showing some of the flaws as to what
Mm.
we were actually doing right now. Patients get scheduled incorrectly by our in-person folks too. It's because scheduling is very complicated. And so having a clear plan of like when that happens, what do we want to do was also really helpful, and it helped us make sure that we were listening to the concerns of the providers. And sometimes it was really the clinical champion saying like, you know, you're an orthopedic doctor. Yes, you're a shoulder guy, but you know enough about the need, at least get the thing started, evaluation started, and then send it on to the right person. And so it's different degrees of figuring out how do we approach those concerns, which was very helpful.
I want to lean in on that because I think that's really important coming from leaders, which is we're going to do everything we can to make sure you have the perfect patients on your schedule, but it's not always going to happen. So the expectation is when that patient is maybe not perfect for that slot, we still figure out what are the one or two things that we can do to get that process going. I think that's really important for our audience to hear.
Absolutely. And the other thing we did, which we're already spending resources on, is saying y'all can still, we call it scrubbing. Y'all can still scrub your schedule. Look at the schedule. We're not saying that you can't look at the schedule and move a patient if you think they'd be better served somewhere else. But we did make it clear you need to get them in a timely fashion if you're going to do that. It's not, I'm going to move you for 6 months from now. And so I think setting some of those parameters, but giving some autonomy within the areas was also helpful.
So listening, helping folks to understand and trust the process, responding to their concerns. Any other areas of concern that you heard commonly?
Yeah, the other thing was about my schedule's already always booked. And so this isn't going to help. And so I think there it was remembering that it's not only about the physician. There we would bring up, yes, we do have a, demand to supply issue. We are trying to recruit more providers, but this is still going to help the folks answering the phone and making those appointments right now, and they will do a better job on scheduling patients correctly when they do have to call in. And so it's thinking of the multifactorial ways that there can be impact and not focusing on just one thing, which maybe it wasn't going to help, but it would help other things.
So understanding how to use all of the care team more efficiently.
Mhm.
Yeah. So as you're hearing all these concerns and responding to them, what do you think ultimately made the case compelling enough to get people coming to you and saying, we've heard about this project, we want to be part of it, sign us up? What do you think made the difference?
I think it was when they started. One is when they saw the website, and so they saw the people live on the website. And we went around and we showed it to lots of people, and we didn't pressure, right? We just went to our clinical leadership meetings with our chief medical officers, with our senior leadership, as well as through some of the departments, and saying, "Hey, this is coming. This is, what we got on. Here's who's live." I think it was primary care and orthopedics were the ones that went live first, and they saw how nice that website looked, and they're like, "Oh, we want this for our patients too." And then we had the data to also back it up that it was doing what it was supposed to be doing. And I think when they saw that, they realized that this was something that was good for their patients, and they really wanted to do it. And honestly, too, they're like, "Oh, nobody imploded. We did this, and the guinea pigs are still alive, so it's okay. We can do it too."
And I really want to highlight that win there. You said primary care, absolutely, maybe start there, but you had your orthopedic surgeons coming to you saying, we want to enable online scheduling for patients. We trust them, we can do this. I think that's really important to highlight.
Absolutely. And they really helped bring a lot of other surgical uh, specialties along, I think, which is great.
So build along the way, have them share their successes with their colleagues as well.
Yep.
Anything else that you want to add here about flexibility and how you sort of shifted your approach to accept feedback and shift your targets depending on what you were hearing?
Yeah, the only other thing I'll say is that I think in all our health systems, we can probably identify maybe there's some areas that take a little less change management, are a little bit more okay with piloting things out and trying things out. And they're often not the areas that will see the most impact from an improvement, right? And so it's balancing out. Yes, we looked at the data. We saw where our biggest discrepancies were between, appointment lag time and schedules. But we also knew that, man, some of these specialties are going to be really tough nuts to crack. And so maybe it's not just about looking at where we're going to have the most impact. Let's also work with some of our areas that are a little bit more open and
Mhm.
able to provide good feedback. And so it was that flexibility of saying, hey, maybe not those folks yet. Let's do these folks over here to be successful.
So when you're thinking about advising others about which specialties to start with, I heard you say start with primary care. And then tell me, what are your thoughts about the next specialties to target? I think that's going to probably vary by health system.
Absolutely, because who you want to work with is a specialty who really wants to improve their access and is working to improve that access. So again, going to the specialty that doesn't have enough providers, and but their scheduling density is very high. that may not be the best place to start. I mentioned orthopedics. They were expanding. They were hiring more APPs. They were starting an urgent care clinic within their one of their sites. And so they were very primed to saying, like, we want to figure out how to get more volume to us. And so they were very open to using this. And so looking for specialties that might be a little bit more open to it, I think is
Hmm.
really important.
I will say, going back to the provider survey that I mentioned before, when we asked providers about what features they needed in order to optimize self-scheduling, I think that fits with your experience. They just wanted to know, like, do we have capacity and what does this mean for us? What we found in our surveys is folks are looking for guardrails, questions, rules, limits on visit types, restriction on time. They want to know that we can really guide the right patient to those slots.
Yeah. And I'll tell you, Sonia, that's part of that was definitely part of what we did during that workflow assessment was we wanted to be responsive, but we would also often say, do you really think we need to ask 10 questions? Do we really need that many questions? Or is it okay with two questions, right? And really bringing up front what is going to be the patient experience if you ask them 10 questions and at the end of it, you say, oh, well, no, based on your answers, I don't think I can schedule you online. Let's not do that. Let's be as cognizant as we can of being as streamlined for the patient as possible.
I think that really highlights the importance of clinical champions in those conversations because you can help to guide those conversations, perhaps in a way that our IT colleagues might not be able to.
Right.
So here's the exciting part I want to move us on to. On the screen here is what patients will see when they go to your website, to the MUSC website outside of the patient portal to schedule, to book an appointment with you. So I want to talk with you about how has enabled online scheduling through this partnership changed your schedules? Like, have you found that you got the wrong patients on your schedules, that you were having no shows? What's it been like for you?
Absolutely not. I have found that the patients are ending up in the right spots. They're good at figuring out, oh, yes, it's asking me if I'm here for a preventive visit or an annual visit or a pap smear or things like that, and clicking appropriately. So we do 15 and 30s. So, we made some clear demarcations on like these things are 15, these things are 30s. This is part of what I was talking about when we started showing this. The other specialties and areas started saying, oh, this is so nice for the patients. You see there, you can see when I'm available. So it's not like I have to go through, five conversations. I can just keep scrolling to find the appointment I want. The other really nice thing is, especially because we have academic side to our practice, is you can see on the map that so my clinic is in West Ashley, so it's the bottom left. If I'm not there, we can show other people in my practice, but maybe, it's the holidays and a lot of people are off. They can then look at other practices close to me and be able to go to one of those to receive the care they need, especially if it's an acute care concern. And so I'll tell you, I got so many comments from the patients saying like this is so much easier now. I don't have to call in and then, talk to somebody through like how do I get a visit today. Instead, they can easily manage this website and decide, are they okay waiting a month to see me? Or do they really need to be seen now because it's a UTI, ear infection, etc.? And then they'll pick one of my partners if I don't have that availability. And so, some of it is put up the guardrails, but trust the patients. And then obviously the other thing we did is we did look at our data. We didn't get a ton of overbooks. We didn't get the providers will complain. We did not get a ton of complaints that people were in ending up in the wrong areas. And if we did see a trend, we could look at, do we need to add a question? Do we need to shut that off? But then be thoughtful about it and understand why we are not including somebody in the online scheduling.
I appreciate that. I think it's so important for our colleagues to be able to look at the actual experience and for you to share your successes, not only with your schedule, but also what you're hearing from the patients. I want to talk for a minute just about some of the success that the health system that MUSC has seen. So in the first 9 months of the partnership last year in 2025, we saw over 16,000 visits booked. Most of those visits were new patients, so contributing to growth of the organization. What I'm most delighted about is what you see on the right here is those appointments were divided between about 60% primary care and 40% specialty. So I really want to emphasize that you all
Yeah.
navigated specialties beautifully. 30 specialties with over 750 providers enabling their schedules for online scheduling by patients. And that provider number, I think, includes residents as well. Is that correct?
Yes, yes, that is correct. And 100% agree. One of the things that I will tell you institutionally was definitely very positive for us is that these numbers to us reflect it's easier for new patients who want to join MUSC and receive their care there to be able to find us now, which is great.
Tell me a little bit more about that. You're the leading provider in this area. Do your providers actually have capacity? Do they have room on their schedules to see patients?
Yeah, so one of the interesting things is that South Carolina is one of the fastest growth states in population, and definitely the metro area where I am in Charleston is one of the fastest growing states in the, or I guess counties in the nation. So because of that, even though we have a brand name, we have a lot of people moving into our area from other areas, and we are a statewide institution but not outside our state, right? And so because of that, I think it's important for us to have that great digital front door so when new people move into the area they can easily find us. And we are always growing, Sonia. We are hiring folks and recruiting, as I think a lot of folks are. And so we want to make sure that we are meeting the needs of the community by doing that, but then also by making it easy for them to find us.
I think one of the ways that we look at meeting the needs of your community is time to care. So I wanted to share this. In the 4 months last year, between June and October, we saw clear evidence that we were helping patients get care nearly a week faster. So for patients booking with primary care providers, their median time to appointment went from just under 28 days down to 21 days. So that's a decrease by almost 8 weeks. So tell me how you think that impacts patients.
I think that's great. One, they're getting to care quicker, but I'll tell you the other thing that we have seen in a lot of data is the longer you have to wait to get to your appointment, the higher your propensity to no-show is. So that's the other thing that is really interesting to us is one, we think this way they're getting to their appointment more efficiently, not having to wait on the phone and not using care team member times. But then two, they're getting the appointment they want faster. And so I think that makes them more likely to actually start engaging in care with us.
It likely improves their outcomes too. We're not missing
Absolutely.
opportunities to address issues before they escalate.
Absolutely. And I think that's one of the things where patient, especially when patients are coming to primary care, sometimes they want to get a really convenient time and they don't mind waiting a month. Sometimes they need to be seen right away. And so I know that in that number, there's going to be a mix of those both types of folks.
Awesome. So I wanted, Vanessa, for you to summarize some of our discussion into those actionable takeaways that folks can take back to their organizations to help improve clinician buy-in for technology. So can you take us through that?
Absolutely. I think the first two go hand in hand. Design with your clinicians so that you avoid adding burden. Otherwise, you're not going to be very successful. Change is great, but you have to know why you're changing and do it in the most efficient way possible. Clearly define those guardrails and expectations. We talked about that too. Don't promise the moon if we can't provide the moon. But folks will go down that road with you if they know what to expect. Just be honest, and it'll give you trust for the future too. And then proactively gather feedback and measure what matters. I think that's the other thing. We don't want to start something and then the providers are doing it and the staff is doing it, and then they never hear back what the impact is, right? And so I think closing that loop is also really important.
Awesome. So we'll go ahead and launch our last poll. We'd love for folks to tell us, based on today's discussion, where will you focus first to improve clinician buy-in? Involve clinicians earlier in discussions, avoid adding burden with new solutions, give clinicians clearer choices or control over those solutions, or measure what matters and report back on the value. So, Vanessa, as we give folks a moment to respond to the poll there, I would say, like, what are your final words of advice to health system leaders when they're trying to gain clinician trust in technology?
I think it's understand the technology before you try to go out and get buy-in for it. Also understand the problem you're trying to fix and talk to a clinician if you're not a clinician to make sure you understand their workflow. And that goes right into understand the problem that you're trying to fix. Because there's great marriages out there of problem and digital solution, but there's also mismatches, and you don't want to end up divorced after like 3 months, you know?
Awesome. Look at these results. I love this. So most folks are focused on involving clinicians earlier in discussions. I think Vanessa's given us a great example of how to do that. Ask for a spot at the table to share. Encourage your leaders when they're starting new projects to do this. So encourage folks to jot this down and remember that this is the next step to take when they're starting those new projects. So we'd be happy to respond to questions from all of you. I already have a few that came in earlier. So Vanessa, maybe I'll start with, what was the biggest misconception from clinicians about online scheduling?
I think they thought that we were going to throw out the rule books altogether and that it was going to be a free for all. The patient found you, the patient would get scheduled. I see one of the questions in the chat is about why there's you were seen in the past 3 years versus not. And that is part of that concept, right? Are you an established patient? You are if you've seen me within the last 3 years, or you're a completely new patient. And we have a couple of questions. Again, we made sure not to be overwhelming, to be able to guide patients to the right place. So I think that was the biggest misconception, that everybody was just going to see everybody and there would be no guardrails at all. And I think the other question I see here is, can these principles be applied to other areas of digital transformation? Absolutely, right? You can define what your problem is, uh, identify who your key stakeholders are, and then be able um, to develop the right digital solution for it.
Perfect. Vanessa, I can't thank you enough for an amazing discussion. I really appreciate your insights and in sharing with us best practice approach for this. So with that, I will hand it back to Daniel for some closing remarks.
Uh, Thank you, Dr. Tarrago and Dr. Diaz. I'm sure the audience joins me in thanking you for that terrific discussion. Thanks also to everyone in our audience for taking the time to join us today. Please note that if you asked a question that we weren't able to get to, we'll do our best to get to a response as soon as we can. And we'll also be sending out a link to the webinar recording, so watch out for that in the next few days. That concludes today's program. We hope to see you at the future forum webinars, as well as the 31st Healthcare Marketing and Physician Strategy Summit, May 3rd to 6th, 2026 in Salt Lake City. Please visit the forum website at healthcarestrategy.com to learn more. Finally, be sure to give us your feedback by completing the evaluation survey as you exit the webinar. Thank you and have a great day.